Hello everyone, welcome to our module on lung cancer. In this video, we'll cover lung cancer. So it is one of the most important and frequently tested topics in pulmonology. By the end of this video, you should be able to identify the type of cancer based on the location, histology, and other associated syndromes. Before beginning with the video, I would like to request all of you to subscribe and keep supporting. This lecture series is provided free and is open access for everyone. If you find it useful and wish to support its development, you can contribute to us with the link that is on the screen and that's also pinned in the description. You can pay us with any of these payment methods. Lung cancer is one of the leading causes of cancer death globally. One of the main reasons is that it is often detected late when the disease has already spread. Smoking is the most important risk factor, especially for certain types like small cell and squamous cell carcinoma. So, from an exam perspective, we always need to pay attention to smoking history. The four main types, all the lung cancers, can be broadly divided into four main types. To solve questions, we need to focus on three things: where the tumor is located, the location, central or peripheral, what it looks like under the microscope, the histology pattern, and what systemic effects it produces or what paraneoplastic syndromes it is associated with. So there are four main types: small cell lung cancer, adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. Small cell lung carcinoma is a highly aggressive tumor that is almost always associated with smoking. It grows rapidly and tends to metastasize early, which is why it is often presenting as an advanced disease state. Importantly, this is a neuroendocrine tumor, which explains many of its systemic effects. Small cell lung carcinoma is typically located centrally near the hilum of the lung. On histology, it appears as small, dark staining cells with very little cytoplasm. These cells arise from neuroendocrine cells in the bronchial epithelium. Because of this origin, they express markers like chromogranin A and synaptophysin. So, coming to the paraneoplastic syndromes, this is the most important concept regarding the exam and how they test on various kinds of exams. Small cell lung carcinoma produces hormones inappropriately, leading to paraneoplastic syndromes. So, it might produce adrenocorticotropic hormone, which causes Cushing syndrome. It can also produce excess antidiuretic hormone leading to low sodium levels. And importantly, it is associated with Lambert-Eaton syndrome, where the muscle weakness actually improves with repeated use. So all these are caused by ectopic hormone production. Clinically, small cell lung carcinoma behaves very aggressively. By the time it is diagnosed, it is often already spread to distant organs. Because of this, surgery is usually not an option. So, if you see a central tumor with paraneoplastic syndromes, we need to think about small cell carcinoma immediately. Adenocarcinoma is the most common type of lung cancer overall. Unlike small cell carcinoma, this is commonly seen in non-smokers and is more frequent in women. Another key distinguishing feature is its location. It typically arises in the peripheral parts of the lung. So, if a question describes a peripheral lung lesion in a non-smoker, so adenocarcinoma should be on the top of our differentials. On histology, adenocarcinoma shows glandular structures and often produces mucin. This reflects its origin from the glandular cells. What makes this tumor especially important clinically is that it is associated with specific genetic mutations like mutations in the EGFR, ALK, and KRAS. So mutations in EGFR, ALK, and KRAS are commonly seen. These mutations are not just diagnostic, they also guide targeted therapy, which is a major focus area in modern oncology. One important clinical feature associated with adenocarcinoma is hypertrophic osteoarthropathy. This includes digital clubbing, where the fingertips become enlarged and bulbous. There may also be new bone formation along the periosteum and joint pain. So, if you see a patient with clubbing and a peripheral lung lesion, adenocarcinoma should definitely be strongly suspected in those cases. Squamous cell carcinoma is strongly linked to smoking and typically arises in the central part of the lung near the major bronchi. The pathogenesis usually involves chronic irritation from smoke leading to metaplasia of the respiratory epithelium. This metaplasia can progress to dysplasia and eventually carcinoma. So whenever you see a central tumor in a heavy smoker, in those cases, squamous cell carcinoma should be the topmost differential. To remember squamous cell carcinoma, we can use the mnemonic 4Cs. So it is central in location, associated with cigarette smoking, shows uh, keratin pearls, uh, keratin pearl formation on histology, and causes elevated calcium levels. Keratin pearls are concentric layers of keratinized cells, and they are a hallmark of squamous differentiation. So, this mnemonic of 4Cs alone can help us solve many questions: central location, cigarette smoking, calcium elevation, and keratin pearls. One of the most important features of squamous cell carcinoma is hypercalcemia. This occurs because the tumor produces a substance that is similar to the parathyroid hormone. This leads to increased calcium release from the bones and increased reabsorption in the kidneys. So, if a patient with a central lung mass uh, has high calcium levels, squamous cell carcinoma is the likely diagnosis. Large cell carcinoma is essentially a diagnosis of exclusion. This means when a lung tumor does not show features of small cell adenocarcinoma or squamous cell carcinoma, it is classified as large cell. It is typically located in the peripheral lung. Because it is poorly differentiated, it does not have specific histological features like gland formation or keratinization. So the key idea here is that if it doesn't fit any category, we need to think a possibility of a large cell carcinoma. One of the most important association with large cell carcinoma is the production of human chorionic gonadotropin. This hormone can lead to gynecomastia in male patients. So, if a male presents with the breast enlargement along with a lung mass, large cell carcinoma should be considered. This is another example of a paraneoplastic syndrome where the tumor produces hormones that affects the distant organs. The fastest way to approach a lung cancer question is to first identify the location of the lesion. If the tumor is central, meaning near the hilum or the bronchi, think of either small cell carcinoma or squamous cell carcinoma. If the tumor is peripheral, it is located in the outer lung fields. Think of adenocarcinoma or large cell carcinoma. So, this simple classification helps us immediately narrow the options by half. Once you identify the location, the next step is to look at the histology. Small cell carcinoma shows small, dark, staining neuroendocrine cells, and it is a highly aggressive tumor. Adenocarcinoma forms glands. It shows glandular pattern and produces mucin. Squamous cell carcinoma shows keratin pearls and often central necrosis. Large cell carcinoma lacks differentiation. It doesn't show up any kinds of specific features. So histology helps us confirm whatever we have suspected based on the location. The final step in solving lung cancer questions is identifying paraneoplastic syndromes. Small cell carcinoma produces multiple hormones leading to conditions like Cushing syndrome, low sodium levels or hyponatremia because of excess of antidiuretic hormone, and Lambert-Eaton syndrome that presents with weakness that becomes better as we start using the muscle. Squamous cell carcinomas cause elevated calcium levels, hypercalcemia. Large cell carcinoma can produce hormones related to gynecomastia. HCG may initiate gynecomastia, and adenocarcinoma is associated with clubbing or hypertrophic osteoarthropathy. So, if a question gives you a systemic feature, we need to use it as a clue to identify the tumor type because it might potentially be one of those features of a paraneoplastic syndrome related to one particular lung cancer. To remember the complications of lung cancer, we use the mnemonic sphere. So this sphere stands for S stands for superior vena cava syndrome, P stands for Pancoast tumor, H stands for Horner syndrome, E stands for endocrine defects or paraneoplastic syndromes, R stands for recurrent laryngeal nerve, and E stands for effusions, pleural or pericardial effusions. So most exam questions will describe symptoms and we just have to identify which structure is being affected. Now let's try to break down all of these clinically. So if the tumor compresses the superior vena cava, blood cannot return from the upper body. So this leads to facial swelling. This leads to facial swelling and dilated veins in the neck that is associated with venous congestion of the face. Whereas a Pancoast tumor occurs at the apex of the lung and it may invade nearby nerves or it invades the nearby brachial plexus and also causes shoulder pain. Pancoast tumor is associated with shoulder pain. Uh, if the tumor affects the sympathetic nerves, it leads to Horner syndrome, which is characterized by drooping eyelid, small pupil, and loss of sweating. So, all these things are classic clinical patterns that we need to remember. If the tumor compresses the recurrent laryngeal nerve, the patient develops hoarseness due to vocal cord paralysis. Pleural effusion occurs when fluid accumulates in the pleural space, leading to breathing difficulty. And endocrine effects refer to paraneoplastic syndromes which we have already discussed in the previous slides. So the key pattern in all these questions related to lung cancer is pattern recognition. So we just need to match the symptom to the structure that is being compressed. Like in superior vena cava syndrome, what happens is there's facial swelling, dilated neck veins, and venous congestion due to obstruction, due to pressure on the superior vena cava because of it being compressed. Whereas Pancoast tumor, there's a tumor at the lung apex where it just invades the brachial plexus and irritation of nerves could lead to shoulder pain. Horner syndrome is characterized by, as we have already discussed, it affects the sympathetic nerves. So, and it is characterized by drooping eyelid, constricted pupil, and loss of sweating on the ipsilateral side. So, to solve uh, whatever it might be. To solve questions related to lung cancer, we always need to follow three steps. First, we need to identify the location, whether it's central or peripheral. Mostly central cancers could be small cell carcinomas or squamous cell carcinomas. Peripheral cancers mostly are adenocarcinoma and large cell carcinoma. Secondly, we need to look for defining features like histology and paraneoplastic syndromes. Small cell carcinoma is usually central. It has neuroendocrine origin and is associated with paraneoplastic syndromes like associated with endocrine derangements in the ACTH, ADH, and Lambert-Eaton syndrome. Thirdly, like similarly, adenocarcinoma, it's peripheral, there's glandular pattern on histology and also mucin production. It is the most common lung cancer, and it's also associated with non-smokers. And the other characteristic feature is clubbing or hypertrophic osteoarthropathy. The other cancer is squamous cell carcinoma. Again, this is one of those centrally located lung cancer lesions. It's associated with smoking, characterized histologically by keratin pearls and associated with hypercalcemia as a paraneoplastic syndrome due to elevated parathyroid hormone related peptide. Whereas large cell carcinoma is peripheral, it is undifferentiated. Paraneoplastic syndrome that is associated with large cell carcinoma includes elevation in HCG, which could lead to gynecomastia. Thirdly, we need to identify complications based on the symptoms. So, if there's facial swelling, it could be SVC syndrome. If there's shoulder pain, it could be Pancoast tumor. H stands for Horner syndrome, which is characterized by ptosis, meiosis, and loss of sweating. And E stands for endocrine or paraneoplastic syndromes. Recurrent laryngeal nerve involvement could lead to hoarseness of voice, and pleural and pericardial effusions could lead to breathlessness. So I hope this video helped you. I'll be right back with a video on obstructive lung diseases. Till then, please subscribe and keep supporting. Thank you so much. Bye.